I want to welcome you to today's webinar from Dave Terry and Archway Health. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I'm delighted to welcome you and to welcome Dave, with whom I've worked for many years and who has worked with MHDC and presented his insights into value-based care, his insights into the evolving marketplace for healthcare, and the evolution of Archway Health. Just by way of introduction, Dave's has over 20 years of experience in healthcare payment reform, both as a strategist and a thought leader. He is the CEO and co-founder of Archway Health. Archway is a value-based care company that's focused on helping employers and providers improve care, reduce costs, and manage risk as the market shifts from volume to value. At Archway, he leads a diverse team of professionals who span data science, reimbursement, clinical care, insurance, and technology to focus on helping providers enter, finance, and succeed at value-based care arrangements. Archway's approach is to use data, its experience, and its market insights to assess opportunity and risk within value-based programs and to help providers manage that risk through innovative stop-loss products and care management tools. David, welcome to MHDC again. We're delighted to have you. And with that, we'll allow you to get started with your presentation.
Thanks, Denny. It's great to see you. Terrific to be here today. Let's see, I'm going to try to share my screen here. And you see my screen?
We do.
All right, let me get to the right. Okay. There we go. Well, again, thanks, Denny, and thanks to Arlene and your team for the invitation to present today. I've got a good number of slides here. Hopefully we'll fill the time with some interesting content, but happy to make this conversational. Denny, as you said, we've known each other for a very long time, back to our days at APM in New York in the 90s. And you and I have been at this for a long time, trying to find ways to improve healthcare, reduce costs, move the market toward value. It's been a fun and interesting career, and I would also say it's been a quest, even more than a career. But so the agenda for today's discussion, I'll give a brief overview of Archway. Thank you for the kind words about Archway, Denny, but I'll give a little more detail and then get into what we see as the drivers of the acceleration toward value-based care in the market. Major value-based care initiatives we're seeing emerge in the marketplace. We'll do a deep dive into the Medicare Direct Contracting Program, which is going live on April 1st, which we think is a very interesting and potentially market-changing program. It's certainly below the radar screen at this point, but it's got some very compelling characteristics, and I think is a good example of how Medicare and the Center for Medicare and Medicaid Innovation is evolving and really going bigger with the programs that they're creating. And then this is the Mass Healthcare Data Collaborative, and so we'll talk a bit about data and how we use data and how we see the increased availability of data changing the way healthcare is purchased and delivered. And then we'll have questions and answers at the end, but as Denny and I spoke yesterday, and Arlene, happy to make this conversational. And as we said in our discussion, I'm very comfortable answering questions along the way, and also comfortable telling you when I do not know. So feel free to jump in with questions as we go. And I know you'll be monitoring the chat.
I will be, and let me just add to that people feel free to type your questions into the chat screen on Zoom, and we will take the questions. And when we're well enough into the presentation, we can unmute the lines and take questions directly, but we want to get a head start and let Dave start. But um, we'll go with the introduction, but please feel free to ask any questions during the course of the presentation by typing into the chat box or unmuting your microphone and asking a question. Go ahead, Dave.
Great. So just a bit about Archway. We're based here in Boston. We do have our technology team is in New York City, founded in 2014. My favorite part about our company and what I get to do is we are an eclectic group of healthcare professionals. I would say we've got a good number of people who I put in my category of kind of healthcare reimbursement and delivery experts with long-standing experience working with providers. We've got a team of PhD and senior level data scientists that are on our team that do a tremendous amount of work with big data sets that we have access to. We've got a technology group. We've got an insurance group that includes actuaries and underwriters and folks who have experience selling into the insurance business. So it's a fun group of folks who are. I think another thing that binds us together is just a passion for trying to find ways to improve care and reduce costs as our industry continues to expand. We are very proud that we're a Medicare qualified entity. So as many of you know, that means that we've got access to 100% of the Medicare Part A, B, and D files for the last three plus years. And we use that data to really model these programs and contracts and try to understand how they perform and what how the rules kind of play out in the marketplace. We've evolved to become an underwriter. So as Denny mentioned, main part of our business at this point is we provide stop loss coverage and reinsurance to folks who take healthcare risk. We've built that from. We started as a convener in the Medicare bundle payment for care improvement program. And as a convener, we essentially were a mini insurance company. We signed the contract with Medicare. We took the risk, and then we shared the risk with our provider partners. And through that model, we developed a number of skills. One was basically underwriting and pricing risk, and the other was helping providers perform within those programs and improve care, reduce costs, and earn savings. And we've leveraged that experience to now we underwrite pretty much any type of healthcare risk. So lots of work in the Medicare programs. We underwrite MSSP and next gen ACOs, providers in the BPCI program and the oncology care model, providers who are taking commercial risk or with commercial plans or Medicare Advantage plans, organizations are doing carve outs and those types of things. And we'll soon, later this year, we'll be launching a product to help provide stop loss to employers who take self-insured employer risk. We've had great success in these programs over the years. We've partnered with dozens and dozens of providers who are in risk arrangements, and we've seen real improvements in the care that's delivered and reductions in costs with just about all the providers that we've worked with. And as you know, there's just a lot of opportunity for improvement in our industry, and we think using data and experience and insights is creates a real opportunity to drive improvement. We are partnered with a company called Coveris. Coveris is the fourth or fifth largest medical malpractice carrier in the country, and they're our carrier partner for the stop loss products that we provide. This has been a great partnership. We've been working with them since 2015 and have started launching these products in 2018. Coveris, we were interested in partnering with a company like Coveris because we wanted to expand it in the insurance business. They're obviously a insurance carrier in the healthcare industry through their medical malpractice business. And it gives us tremendous capacity and access in the market for underwriting these different programs. And Coveris was interested in partnering with us. They're a leader in their space, but they wanted to help their customer base, providers, take and manage risk in different ways beyond medical professional liability. And they've been quite innovative in the products that they've developed with us and with others. They're an A-rated carrier with significant capacity. They've got a seat at Lloyd's, and strong relationships across the marketplace. And it's really just been a good partnership for us. And for a relatively large insurance company, Coveris has been quite innovative, and we've been just extremely pleased to be in a relationship with Coveris.
Just as a shameless promotion, we also had Bob Hanscom do a presentation with us just last week. So
yeah, I saw that. I should have mentioned that. Yeah, so Bob is terrific, and Bob leads the admin, as I'm sure you know. Coveris has a tremendous amount of data as well, and part of their focus and what led them, what created the opportunity for this partnership between our two companies is they're very data driven as well, and doing lots of interesting things with the data that they have. We're combining our data sets really to try to understand the healthcare landscape and what drives improvement. All right, so transitioning to the next section here, really drivers of the accelerating market, the value-based care marketplace. So I'm going to start at a very macro level here, just looking at the federal debt. This is actually data pre-COVID. It's gotten worse since this chart was produced, but as I think many of us know, that our debt levels are at unprecedented heights here, higher than they've ever been as a percent of GDP. And we spent a lot of time talking to folks at CMS and HHS, and what the message that we're hearing is that it's just unsustainable at some point. And certainly we're in a recession now, and it makes sense for the government to be spending to help us through the recession, but it's not helping where we are from a debt perspective. And this continues to grow. When we look at what's driving debt, it's healthcare. Healthcare, of all the things that we spend money on as government, healthcare is the most out of control, and obviously will continue to grow at these rates as the population ages. And so, in our conversations with regulators as well as economists, there's something needs to happen to think through, how do we get this under control and manage the spending and manage the debt? And so that's a big driver from the government perspective. And really, we've been working with Medicare and the Center for Medicare and Medicaid Innovation, CMMI, since CMMI was created out of the Affordable Care Act. And that organization really exists to find ways to bend the curve and create new value-based programs. And we think they're doing a great job. I mean, it's hard work. It's complicated, but they've, with CMMI, the government really transitioned from putting out relatively small pilot programs to creating new value-based payment models at scale. And they continue to, expand the models that they're developing and roll them out beyond just demonstrations, really kind of big programs with the focus of trying to shift, bend the curve and shift toward value, because it's a national imperative. And it's no coincidence that it is Medicare that's starting this, because they hold more healthcare risk than anybody in the country. And they, ultimately they hold the risk, they can't get out of the risk, and they have to find ways to continue to, drive improvement and reduce overall spending.
Dave, just as you move forward, just one of the questions that I think might be helpful for those in our audience is for you to talk a little bit about how Medicare risk programs have evolved over the years. I mean, we've started, I don't know how many we've been through, probably several dozen, but it would be at some point great to learn from you. Can you hear me now? That's probably a little better. It would be great to hear from you a bit about the evolution of value-based programs over the course of the years.
Yeah, so I do have a slide on that later. Actually, Michael Chernew, who is a healthcare economist at Harvard and now is the chairman of the MedPAC board, is on our advisory board. And talked to him just the other day, and we're in touch with other regulators in DC. And there is significant evolution happening really right now in a lot of those programs and the way they think about that. So I will get to that as we go through. And I guess this is one way that this is one indicator of the evolution. So in 2019, Medicare came out and said that they wanted to shift away from these upside only programs to programs that have significant downside or meaningful downside in them, and really expand programs so that they more of the market is participating in meaningful risk. And their studies indicate that these programs are working to some degree, but the ones that have real downside risk are working the most effective. And so they came out with a goal to say that by 2025, they want 100% of Medicare providers to be in some type of downside risk arrangement. That doesn't mean that all their patients or all their Medicare patients are in a risk arrangement, but they do want all providers to be in meaningful downside risk arrangements if they're providing care to Medicare fee-for-service and Medicare Advantage beneficiaries, and the goal of having 50% of providers be in some sort of commercial or Medicaid risk arrangement. And so this is a massive shift in risk from the government into the private market. And so the numbers are certainly large, and it's hard to kind of pin down exactly where we are and where we're headed. But we think this is roughly about $1 trillion of risk shifting from the government or from the payer market onto providers in our economy. And so, as you can imagine, this is a seismic change, and certainly something that will change the way healthcare is delivered, change the way healthcare is financed, and how providers think about their role in delivering care and how they're organized to deliver care. Another part of so that's kind of the macroeconomic drivers of the shift to value-based care. Another governmental component of this is the regulatory environment, and kind of how that area is changing and encouraging folks to shift to risk. So folks may have seen in the second half of 2020, there were significant changes and updates to Stark and anti-kickback rules, which govern much of what we do in healthcare. Some of it we feel directly when we're trying to get things done, and some of it is just sort of this invisible force behind the scenes that is shaping healthcare delivery and healthcare arrangements. But some of the things, when these regulations came out, or in the period leading up to these regulations, lots of discussions around the intent of why these are coming into place. And really, it was around moving toward value-based care, facilitating engagement of physicians, both from an incentive and a financial perspective, thinking about how to use technology and pay for technology in ways that aren't allowed with Stark and any kickback statutes. And so creating some freedom so that health systems could pay physicians to use technology tools, or have arrangements between technology companies and health systems that aren't allowed in Stark. But the new structure of the law allows for this in much more creative ways, moving the market toward risk. So there's a lot more freedom within these Stark and anti-kickback rules as providers take on risk, and really, ultimately, I would say facilitating the coordination of care and paying folks to participate in coordination of care, or doing different types of things that are often precluded within Stark. And so the freedom, it really, a lot more freedom within a full risk arrangement. And some of the features here are, one at the bottom is that if you're in a full risk arrangement and are looking for exceptions or safe harbors from Stark, you don't need to document it. You can just move forward with those arrangements. Obviously, you need a lawyer, healthcare regulatory lawyer, to help with all these things. But the degrees of freedom are significant if it's a full risk, capitated or some sort of carve out type of relationship. And there's still, these new rules create more freedom if it's not full risk, but with meaningful downside risk. And so, the arrangements need to be written down if it's not full risk, but they don't need to be signed. And so, it just, again, creates more leeway and more freedom for how to implement these programs, and pay physicians to do certain things or pay health systems to do certain things, that aren't allowed under Stark. And then even if there's no risk, if you can show that the intent is to move toward value, coordinate care, and pay physicians or other participants to do those types of things, there's more leeway under the new rules than there used to be. But in a no risk situation, those arrangements need to be heavily documented and obviously signed, and those types of things. And so just much more flexibility in any case, whether there's no risk or full risk, but certainly as you move toward more risk, the flexibility becomes much more significant. And just some examples. Yeah, go ahead.
Just as a quick question, we have two questions from the folks. In our audience. One is from Janice Karen. As we move away from fee for service, do you see any commensurate changes in the patient cost portion of the equation? It's still very much a fee for service type of arrangement as far as patients are concerned. How do you see this affecting patients on the other end of these arrangements?
Yeah, so absolutely. So I think, we'll talk about this when we talk about the direct contracting model. And there's more leeway in these as providers take on more risk. There's more leeway in what they can offer patients in terms of incentives for engagement, forgiveness of copays and deductibles and those types of things. And so, just as we're trying to incentivize, providers and physicians to move toward value, we are seeing incentives for patients to engage in different ways. Certainly seeing that in the employer market, and again, we'll see in the direct contracting program. That's a Medicare fee-for-service program. It's not a managed care, traditional kind of managed care program, but they're creating incentives for providers to have preferred networks and channel their patients toward those preferred networks using incentives and those types of things.
We also have a question from Janice Pocchini, who asks, do you see adding to the base fee to drive physician engagement in the risk idea of these emerging products?
You mean, so I'm hearing that question as sort of adding to the base physician fee. So paying the physician more essentially to do certain things. 100%. Right. Yeah. I mean, I think there's a variety of ways to do this. You can pay more for certain. So I would classify that as a pay for performance type of setup. And so, yeah, you could see, paying someone 100% of Medicare and then a bonus for doing certain types of things, or maybe 90% of Medicare with a 20% bonus for doing certain things, so that there's, some downside and some upside in that relationship. But we're certainly seeing participants in these programs pay more under certain circumstances in exchange for other types of activity. And I think these are some examples of that, right? So, these are some examples of more flexibility created through the updated regulations. In terms of like patient tracking technology, paying, as long as you can prove that there's a value-based purpose to the initiative, you can pay physicians to use these types of tools in different ways in the new rules than you could in the old rules. So paying physicians or their offices to track their patients more proactively. There are also some patient incentives that are now more allowed for incentivizing patients to use these tools in new and more effective ways. Another example would be, a huge part of, particularly in Medicare, a huge part of driving improvement is tracking patients post-discharge from the hospital. There are new reimbursement programs within that arena, like the RPM, the CCM, chronic care management programs, and the the RPM program. It's a patient monitoring program. And so physicians can get reimbursed for doing post-discharge visits and those types of things. In this scenario, again, because of the new updated Stark and anti-kickback rules, hospitals can pay physicians, health systems can pay physicians to do that type of work, particularly if they're in a risk arrangement. Obviously much easier to do, to be in a safe harbor if you're in a risk arrangement. And so these are just a few examples. I am not a lawyer. This was developed in partnership with our lawyer, but lots of opportunities to think differently about how to, incentivize coordination of care and improvement in helping patients, not get readmitted, not avoid unnecessary ER visits, hospitalizations, and improve quality of life. Those types of things that really are moving the market toward value. Third area would be, beyond the macro environment and the regulatory environment, a third area would be provider market demand for more value-based care arrangements. And I'd say there are three sort of things that we see related to this in the market. The first is, providers just have more experience now than they did a few years ago. And as Denny, as you mentioned, there are over 50 different value-based care programs that CMMI has created in the last half a dozen years. Some of the bigger ones, obviously next-gen ACOs and MSSP ACOs and the bundle payment program and those types of things. But there's value-based purchasing, and there's home care programs, and there's different regional programs and post-acute programs. And so through these initiatives, many more providers have participated in some type of risk program. Could be a big contract or could be a smaller demonstration, but, and they've made investments, they've gained experience, they've gained confidence and capabilities. We had a provider recently, a large cardiology group in Louisiana that we work with. They participated in the Medicare bundle payment for care improvement program starting in 2018. That program had some rule changes this year that essentially made it much less attractive for them to participate in. And so they didn't participate in that program starting in 2021, but they're dying to find a next program that they want to get into, because they had success in that program in the previous iteration. They've invested in care coordination and nurse case management. They've trained their physicians, and they're out of that program now, but they really want to try to find the next thing to participate in to leverage that learning and those assets. And they'll probably end up participating in some way in the direct contracting program. The second is related to COVID, and I'm sure providers on the line have experienced this. In a year ago, between middle of March and June, I would hazard to say every provider in the country felt reduction in volume in that period of time, and some significant reduction in their fee-for-service revenue. We do a lot of work in orthopedics. Many of the orthopedic practices we work with in that second quarter of last year saw a 90% reduction in their volume, with electives shut down in much of the country. And if they're all fee for service, that's a 90% reduction in revenue while they're continuing to pay rent and support their office staffs and those types of things. And so we saw a lot of interest coming out of that. And then some of that picked up certainly with telehealth and those types of things. But we saw a lot of interest coming out of that, and providers trying to identify ways to diversify their revenue beyond fee for service, smooth their cash flow and their revenue streams with more capitated models or models that include some sort of per member per month payment. At the same time that we saw providers struggling in that period, payers did quite well. This is a generalization. I'm sure there's some that didn't, but many payers continue obviously to see their premiums come in, but providers aren't in that position if they're 100% fee for service. And so this is another market driver of demand for these programs. And the third would be, that what we're seeing in the public and private market, particularly in some of these newer types of delivery models. Oak Street, you may know, is Chicago-based, provide a primary care and chronic care management business focused on the Medicare Advantage community. They essentially subcontract on a capitated basis with Medicare Advantage plans to care for general Medicare Advantage members as well as Medicare Advantage members with chronic conditions. Signify is kind of a home-based. Signify and Landmark are both kind of home-based companies that care for seniors in their homes and take risk with Medicare Advantage plans for doing that. Agilon, I would put in a similar category to Oak Street. There's other companies like Iora and ChenMed and others that are in these similar categories. The valuations that these companies are getting right now is crazy. Oak Street went public, I think, in the fall, August, September timeframe, of that, I think, a $13 billion valuation. And they're doing this because they own the premium dollar for Medicare Advantage plans, or a big chunk of it. And they're just better at managing care for patients who, I haven't studied Oak Street that closely, but they claim to be, and certainly Wall Street seems to be valuing them at being better at managing the care, reducing costs, hopefully improving the care for patients in those categories. And it's attracting a lot of attention in the market, for sure. I don't know, Denny, if there's any, I think I'm going to have to transition to the next section here. Happy to pause there. So just to summarize, the big drivers are the macroeconomy, certainly Medicare and CMMI driving this direction, regulatory changes that facilitate and make these programs easier to implement with less restrictions and legal hurdles to get through, and then provider demand from the marketplace to participate in more of these programs, whether it's from Medicare or from the commercial market.
Dave, we see a lot happening for Medicare, and where Medicare leads, commercial insurance follows. But we also see a lot of Medicare Advantage. People are jumping on Medicare Advantage as sort of the place where risk-based arrangements have the greatest opportunity to succeed, at least at current reimbursement rates. What do you see the commercial? How does this evolution in value-based care affect other commercial products beside Medicare Advantage? We know we have, I think you showed the AQC, which is the alternative quality contract from Blue Cross. Are you seeing other payer markets adopting and adapting more and more value-based programs to sort of coincide with this evolution or revolution from CMS?
Yeah, so I would say a couple things about that. So certainly there are regions of the country that are leading the way and are much more active in shifting risk from the payer to the commercial market to onto providers. Massachusetts, and what Blue Cross Blue Shield kind of led the way with developing the alternative quality contract. Southern California is big, parts of Florida, those types of things and those types of areas. I would say it's still relatively nascent, though, for the most part. I think it's starting in Medicare Advantage for good reason. Obviously, a lot more spending in the senior population, and so a lot more opportunity for improvement and thinking differently about how to manage those dollars. It's harder to do in the commercial market because the spending is more dispersed. But we are certainly seeing, and I think we're seeing the activity pick up. Blue Cross of North Carolina is doing a lot, Horizon Blue Cross of New Jersey, Blue Cross of Michigan. And so I think it's still pockets of activity. But I think, one thing you said a moment ago is, when Medicare does something in a big way, it creates a pathway for the commercial market to follow. And certainly there's a lot of activity in Medicare Advantage. And what Medicare is starting to do, getting your question of kind of how Medicare is evolving, it's clear to us that Medicare would like to see more, if not all, of their members in some sort of managed model, and so they pushed Medicare Advantage for a long time. Medicare Advantage penetration is still kind of capping out at 35 to 40% of the market, and it's been hard to get above that. Medicare beneficiaries voluntarily choosing to be in a managed plan. And so when we look at the direct contracting model and some of these other programs, it's clear that what they're doing is pushing their beneficiaries into a managed product through the providers who care for those patients. And I think that's going to have the tipping point. This issue of increasing provider demand to be in these programs. It's one thing to be in an AQC contract and maybe even a Medicare Advantage risk contract where maybe 20%, 25% of your patients are in a risk model. But if all of a sudden all of your Medicare fee-for-service patients are in a risk model, now you're getting to 40%, 50% of your patients in a risk model. And once you kind of get to that tipping point, providers will seem to start looking for, how do we not have our feet in two different boats here, fee-for-service and risk? How do we get more and more of our beneficiaries or patients in a risk model? And I think that's clearly where Medicare is heading, and I think that'll help pull the commercial market more into these risk arrangements. Another factor there is certainly employers are pushing in that direction. We know Walmart, Amazon, Boeing, they've been trying to push in that direction for a long time, and they continue to do that. And I think having providers with more experience in risk will help, and then also all the data that they now have at their fingertips to build their networks will also be a factor.
One of the big areas that seems to be an untapped pool for innovation is Medicaid. We have in Massachusetts, the Mass Health ACOs. We have, a waiver in Massachusetts to do some pretty innovative things with respect to engaging providers in at least marginally risk-based arrangements. I don't mean that critically, but I think this is an evolution in Medicaid. Do you see Medicaid being we have provider members of the consortium who are building businesses around taking care of Medicaid patients. Do you see that being a market for innovation in the coming years?
Absolutely. Yeah. So in many states, vast majority of Medicaid beneficiaries are now in some sort of managed product. And there's, lots of waivers that have been put out for states to do to care for their Medicaid beneficiaries in various ways. And so that's another, incubation area for different ways to, pay for care, deliver care, manage populations. Lots of activity in the duals populations. Commonwealth Care Alliance here in Massachusetts has done a lot of work there. I know others have. But that's a population obviously with significant needs and very high premiums. And so for folks who can, challenging clinical areas to manage, and so you have to really know what you're doing. But for folks who do know what they're doing, there's lots of opportunity to improve care, improve quality of life for those beneficiaries using those dollars in different ways and hopefully wiser ways.
Thank you.
Okay, so next section is really what we're seeing as some major initiatives in the value-based care arena. I know many of the folks here are very sophisticated, but for the way we think about this is, at the end of the day, there are two models, and there are lots of variations within the two models, but the one model that I think gets the most attention and is kind of the biggest type of model is an accountable care organization, which essentially is a population health management approach, where generally driven off of starting with attributing members to an ACO via their who their primary care physician is, and then putting the primary care organization or the health system that they're affiliated with in charge of all of the spending and all of the care for the patients in their in their population. And there's all kinds of different risk models stemming from that. But essentially, it's a population health-based model where someone is in charge of looking out for all the downstream, all the primary care wellness activities and all the downstream care that happens with those patients, specialty care, hospital services, post-acute care, and then even augmenting that with patient segmentation and technology tools and those types of things. And there, certainly we see ACOs growing. This is the most recent data that I've been able to find, but through the end of 2018, growth in ACOs in the commercial market and in the Medicare market. I do think it has plateaued a little bit with some folks have dropped out of the next gen program and the MSSP programs, and so there's been some in and outs there, but certainly seeing growth in the ACO and the ACO model. And I think certainly seeing evolution in the way that Medicare is designing these programs and commercial markets are designing these programs, and we'll talk about that when we get to the direct contracting initiative. The other model is what we think about is a bundle payment or some sort of specialty risk arrangement. And in this scenario, and this is where we started Archway when we first created the company, is focusing on identifying a specialist who's in charge of patients' care while they're in some sort of acute or chronic episode. And in this scenario, we're putting the specialist in charge of the process from the point of a diagnosis or a hospitalization. There's some sort of trigger event. Could be a diagnosis, could be a surgery, could be a hospitalization, but some sort of trigger event. And now the specialist is in charge of the process. The specialist and their team are in charge of the process for a defined period of time. In the Medicare bundle payment for care improvement program, it's a 90-day episode, and it includes the vast majority. It's a voluntary program, but they've defined episodes for really the vast majority of what Medicare does: orthopedics, cardiac care, complex medical conditions like COPD or congestive heart failure, GI procedures, medical care related to pulmonology or cardiology. And then also they created the program called the Oncology Care Model, which is a 6-month episode focused on Medicare beneficiaries who have initiated a course of chemotherapy. And then, there have been bundles around for complex things like transplants and kidney care and those types of things for some time. We started in this program. So earlier in my career, I worked at Partners, and we had global capitated contracts with Medicare and commercial plans covering about 400,000 lives. And we had an ACO kind of model, primary care attribution model. And this was in the early 2000s. And we really struggled to succeed in those contracts. And one reason was the primary care physicians were capped, but the specialists still got paid fee for service, and the hospitals got DRG payments, and the skilled nursing facilities got per diems. And we struggled to find ways to engage the specialists in the value-based care process and move them away from just plain fee for service or some RVU model. And so what I love about the bundle payment structure, and there are lots of ways to structure these, and all the structures aren't great, but just the concept is, it is a way to identify which specialists are really doing a good job, hold them accountable for not just their portion of their procedure or the visits that they do, but hold them accountable for the outcomes and the process, and also reward the ones who were really good with enhanced payments through some sort of bundle model. So there's lots of permutations on these, and you could instead of a bundle, you could have a specialty carve out or something like that. But at the end of the day, the way we see it, it's either some sort of primary care attribution ACO model or some sort of specialty focused bundle model. And then we start looking at the various programs that are coming out and kind of how we categorize them and who they're targeted at. And there are dozens and dozens, as you said, Denny. So, we see a lot of hospitals and health systems participating in ACOs. And even in some bundle payment programs like BPCI Advanced and OCM and next gen MSSP ACOs, primary care groups, the direct contracting program is quite attractive for primary care groups. There's a primary care first program, which is sort of a primary care capitation model, sort of capitation light model. We do see primary care organizations participating in ACOs. And then for specialists, there's all kinds, there's sort of an alphabet soup of programs, whether it's BPCI Advanced or the ESRD model or the new Kidney Care Choices program. There's a radiation oncology model that's coming out. There's an emergency care model. There's lots of different programs for specialists to participate in. And then, as I mentioned, there's new entrants coming in. There's a lot of private equity money going into specialty specific risk programs. So lots of activity in chronic kidney care management, lots of activity in maternity and managing that whole, the whole process from, initial visits with an OB all the way through the NICU, activity in maternity in the Medicaid market. Something like 50% of births are paid for by Medicaid across the country. And so activity there, we're seeing folks investing in orthopedic groups to do carve outs. So, I would say lots of activity across the board and in many of these types of contracts.
Full of questions, Dave. From Janice Karen, do bundle payment models only cover those things related to the condition or all the care the patient needs during that time frame?
Yeah, so those models have really evolved to basically say, once the bundle starts, everything's included. And so, like, if you think about a patient who has a stent, say, put in, we do a lot of work with cardiologists, interventional cardiologists who do stent procedures. Once that bundle starts, that's a 90-day in the Medicare, that's a 90-day bundle. Any readmission that occurs post that procedure is part of the bundle. There may be an exception for a trauma, say, or a cancer diagnosis, but anything else is included. And we think that makes sense. We certainly talk to providers who initially don't like that, but we think it makes sense, one, because it's simpler. You don't have to sort of figure out what's included and what's excluded and what's causal and what's not. We also, think that it's included in the performance period. It's also included in the benchmark pricing, right? So, all those things that happen to the patient are kind of worked into the overall pricing. And so you got to get you have responsible for the cost, you get benefit in the benchmark. And the third is that look, the goal is to improve the care for the patients. And certainly some random things are going to happen that are outside of anyone's control. But if your sample size is big enough and you're really working hard to have an impact on helping those patients recover, get back home as quickly and safely as possible, patients can benefit from better coordination and proactivity in managing their care, once they've had that acute event. Sorry, Denny.
Pharmacy costs play a big part in swinging the cost of healthcare. Could you talk a little bit about how these programs might deal with this, this huge bolus of expense that's associated with drugs and with increasingly, expensive, better, but much more expensive medications than used to be the case?
Yeah, good question. And so the drugs are treated differently in different programs. If you look at a lot of the ACO programs, Part D drugs are excluded. In the BPCI program, Part D drugs are excluded. In the oncology care model, interestingly, drugs are included, and that can be controversial. We think it's hard to create a cancer bundle without including drugs. Drugs typically are 50% of the cost for a patient who's in chemo. So but then you have to deal with these issues around new technologies and those types of things. And so, different programs treat drugs differently. We generally like to see drugs included, but with some sort of either carve out for new technologies or some sort of risk bands to deal with kind of again new technologies or anomalous spend or those types of things. A lot of programs will start. I think where they're headed with direct contracting. So direct contracting is starting where it's just A and B. So it would include drugs covered under the Medicare B, not Medicare D. But it does seem like they're signaling that they may move to expand it over time to include both.
Thank you.
So this is, I think, 30 minutes later, Danny, getting to your question earlier. When talking to Mike Chernow and some other folks in the last couple of months, where Medicare is headed, sort of CMMI phase 2. So I mentioned there's been over 50 programs in the last 6 years or so. I think now they're transitioning. They've learned a lot from those programs. Some of them have been more effective than others. I think also some of them have suffered from program overlap, and with so many programs, it's hard to study how all of them are working and whether what's driving what. But so I think what we're hearing is they're moving toward fewer but bigger programs to limit this issue around overlap, have more clarity in the market or kind of what these programs are. Definitely moving toward more up and downside risk. And studies have shown that downside drives improvement faster, more effectively than just upside, and meaningful downside is important. We've always liked this concept of ACOs with bundles underneath, right? So some incentive and model where primary care is really engaged in managing the health and wellness of their population, but then there's also accountability at the levels at the downstream once you make referrals to a specialist or to a hospital for them to manage what they're good at. We have a strong orientation toward expertise, and we've learned just looking at the data and working with providers that expertise really matters. I would say that's probably true in everything. Certainly true in healthcare, but in fee-for-service, unfortunately, there's a lot of dabblers. A lot of people who do a lot of different things and aren't great at aren't necessarily great at all of them. And as I think about it for myself or my family, if I have a family member who needs a bypass surgery, I want to make sure that surgeon is great at bypass surgery. And not all of them are. There's a bell curve for everything. And so having more accountability and that expertise factor, we think is really important. And this concept of ACOs with bundles underneath, we think starts moving in that direction. And the last piece here is, they have talked about wanting to shift more of these programs from voluntary to mandatory. And there's some mandatory programs that have been created. There's the chronic joint replacement program, or CJR, which is a mandatory hospital-driven bundle for hip and knee replacements. They came out they announced a mandatory radiation oncology program that hasn't been launched yet, but they're talking about potentially a mandatory program for certain types of cardiology care. And I think there are a couple of reasons for this. One is they do want to move the market away from fee-for-service, and it's hard to do that when it's all voluntary. The second is, in voluntary programs, they have a real adverse selection problem where only the providers who are really good are deciding to participate or are advantaged in the program, and others don't. And it just makes it hard to drive change at scale.
Dave, one of the things that comes up as a question in my mind is, is the hospital or the health system as the agent of change? In many respects, it's really the physician, or the clinical provider, the individual who is either as a primary care practitioner or as a specialist, having the relationship with the patient. The hospital is an enterprise. It's a facility. It accounts for a fraction of healthcare of the healthcare experience of most people until late in their life or when they become very ill. Are physicians better positioned to move forward with value-based arrangements than hospitals and health systems? There seems to be an awful lot of infrastructure to haul along into these risk arrangements for organizations that are as large and as asset intensive as hospitals. Can you shed a little light on that?
Yeah, and I haven't scrolled to the list here, but I'm guessing we've got representation, a lot of representation of both on the line. So the studies have shown that physician-driven ACOs and other physician-driven ACOs and owners of these bundle payment programs have had a more of an impact and a faster impact than health systems. And I think it gets to your point of it's hard to turn a battleship. And also, I think a lot of these independent physician groups are small, medium-sized businesses where they have to perform to to earn their living, frankly. And bigger health systems have more of a cushion, and it's just and so it's harder to turn them. The imperative might not be quite the same. So that's what the studies show. The physician groups do outperform health systems. And Danny, you and I started working in this area too long ago to say. I think for a long time we felt that the market would shift away from hospital beds and more towards managing health and managing services. It's been a slow process, but we certainly do see. And I think another challenge is hospitals and health systems, they have much bigger balance sheets, right? And they can afford to invest in the resources that are required to move in this direction more so than a physician group and other types of organization. And so we've seen health systems acquire primary care physicians and acquire specialists and try to move in this direction. And so certainly I think we'll see more of that. We're also seeing a lot of private equity money and other and public market money come into financing the transition more through physician organizations. So it'll be interesting to see how that plays out. Most health systems in America make their money on fee for service, and so it's just hard for any large organization to say, "Geez, we've done really well for so many years on fee for service. We're going to give that up and change and shift to our revenue coming by keeping our beds empty as opposed to keeping our beds full." Not an easy change in any industry, and so I think we'll see how it plays out. But I do think new entrants will have a big impact on the market.
Thank you, Dave.
Okay, so we'll do a deep dive here. I mentioned this a couple of times. We'll do a deep dive into the direct contracting program, and well, Danny, I appreciate the questions. It's I feel like I hope I'm not droning on too much in the course of this webinar, but happy to take more questions as we go through here. So this is a cut and paste from the Medicare CMMI side about the direct contracting program. I've got some other slides that are my own here coming up, but just to kind of cover the basics. The direct contracting program essentially is a large ACO model with a couple different risk sharing approaches. There's the professional model, which essentially is a 50-50 risk share, opportunity share. So if you enter into the direct contracting program in the professional model, you're responsible for 50% of the spending and you can earn 50% of the savings. Well, you're responsible for all the spending, but you only exposed to 50% of the downside and 50% of the upside. In the global model, responsible for all of the spend, and it's 100% up and down, right? So there's some risk corridors, but they're very, very broad risk corridors. And so essentially it's a fully global capped model for Medicare fee-for-service beneficiaries, excluding Part D drugs. And it's both of those models are what I would call primary care attribution. So if you're a primary care group and you want to participate in this program, once you sign up and are in, all of your Medicare beneficiaries will be part of this. Fee-for-service beneficiaries will be part of this program and will be used to establish your benchmark, and you'll now be at risk for managing all the care for those beneficiaries. And if it's professional, you have half the risk. If it's global, you have all the risk. The geographic model was just a couple of weeks ago, has been suspended, which we thought might happen coming into the new administration, and it's unclear whether that'll be kind of reinstated. But that program was essentially an application process where organizations could apply in various markets across the country to become a direct contracting entity, and they would be assigned at least 30,000 Medicare beneficiaries in a market. So it's almost like we expected a lot of Medicare Advantage plans to participate in this. And, if Miami, Boston was not one of the markets, but Miami was a market. So you could apply to become a geographic contracting entity in Miami. And if you won that contract, overnight, you would have at least 30,000 beneficiaries in that marketplace, be responsible for managing their care within the model. That was a bit controversial and has been suspended. We'll see if it comes back, but the global and professional are well underway, and the first participants in those programs will be starting on April 1st. There are a number of what I would call game-changing attributes. I'm going to focus mostly on the global risk model within the direct contracting program. That's 100% up and down risk. And I would say we spent a lot of time in this program. We're underwriting providers who are participating in this program. We're talking to primary care physicians who might want to work with us in this program. I would say there are three big attributes that we think are different, certainly from what we've seen so far, and I think are game changers. So the first is, this is a prospective payment model. Just about everything that Medicare has done so far has been retrospective reconciliation, where they establish a benchmark, they continue to pay, Medicare continues to pay fee-for-service to all providers, and then they settle up after the fact. And so your cash flow could be 9 months, 18 months. The benefit of that, if you're successful, the benefit of the savings you earn, you're not going to see for 9 to 18 months or so after you've seen a patient. In this model, traditional capitation, you get your money up front and a PMPM payment. It's for all your Medicare beneficiaries. If you're a primary care organization, your Medicare fee-for-service beneficiaries. There's a voluntary attribution aspect too, where patients can sign up with you. We expect most patients will be aligned through, just by who their primary care physicians are. The other game changer here is this is not a shared savings program. So in the global program, there's a process for setting the benchmark. The benchmark's a mix of kind of Medicare Advantage rates. It's a blend of Medicare Advantage rates and the provider's historical experience. There's a 2% discount to start against the benchmark. There's a 25% up or down risk corridor. 25%, as you can imagine, is massive. In 2012, shortly after CMMI was created and the Affordable Care Act had directed, CMMI to create. They directed them to create ACOs and bundle payment programs. I was part of a group who was thinking about creating a company to facilitate providers building ACOs. And when the regulations came out for Pioneer ACOs and shared savings ACOs, it just didn't pencil to, certainly for provider organizations who had infrastructure, for some provider organizations who had experience in infrastructure, it made sense. But for us as a third party to help folks get into these ACOs, the math didn't work because you had to wait a year to get any revenue once you get started. And if you had success, you had to give a big chunk of the savings back to Medicare. And so it just didn't pencil to make it work. And these two changes deal with that. Get your money up front, and it's not shared savings. Now, the corollary to being not shared savings is it's not shared downside either. And so it's not for the faint of heart. But if you believe there's opportunity for improvement, it's a very enticing model for provider organizations who are well-positioned and have experience, and new entrants who feel like, or like Oak Street or Agilon or some of these folks who feel like they have the ability to manage these populations. The third is I think, a unique attribute, which is significant incentives for specialty risk arrangements between the primary care physicians and specialists. And there's a twofold incentive here. So I would argue, and this is the reason we created Archway, is that an essential part of improving care is partnering with really good specialists. And holding those specialists accountable through different types of risk arrangements or incentive plans. And our math says 75% or so of healthcare spending is really driven by specialists. And this is a rocket science observation, which is people spend money when they're sick. And when they're sick, they're with specialists, and that's when they need the most care and most attention and the most specialized needs. And that's when they'll spend the most dollars. And so we don't think an ACO or any type of program like this can be successful without really thinking carefully about who delivers specialty care, how good are they, and what are their incentives. So that's one part of being successful. The other part, this attribute in this program, is in order to access the PMPM dollars for specialists, you have to have an agreement with those specialists. So if you're a primary care organization and you're in a DCE program, the DC program, you're at risk for 100% of the spend, but Medicare is only going to give you upfront the primary care related dollars. In order to get the cardiology related dollars, you have to have a contract with cardiologists in some sort of specialty care management arrangement. And so now there's this dual incentives of, one, in order to be successful, I need to work with good cardiologists. And in order to get the revenue to manage those cardiologists, I have to have an agreement with them. I think that's a big game changer, because now that's going to change to whom the primary care physicians refer, how they share data, how the payment arrangements work, and a whole variety of things. And so, this diagram is meant to sort of outline the way it works. So in the direct contracting program, there's a direct contracting entity. That's the organization that enters into the contract with Medicare. That could be a health system, that could be a primary care organization, that could be a third party. But the direct contracting entity enters into the contract with Medicare. They have to have relationships with primary care organizations in order to get attributed beneficiaries into the program. So contracts with primary care are required to get started in the program. And then these relationships with specialists are optional. So, but in order to do well, I would argue, and in order to get more revenue into the top of the funnel, you have to have those relationships with specialty organizations. And then, and this is a bit about how the dollars flow. So these are preliminary numbers and these are rough, but for in Massachusetts, the typical PMPM for Medicare Advantage beneficiary, which is not exact, but a reasonable proxy for direct contracting, is about $850, $860. That excludes drugs. With a discount, it's about a $51 million budget. Primary care would you get PMPMs of $40 to $50 for that population, about $2.7 million of the budget. There's some enhanced primary care reimbursement in this program to facilitate investment in infrastructure and those types of things, so they get a little bit more money than what they would normally get in fee-for-service. But then this is how the dollars flow, not all the dollars, but this is sort of the big areas of where Medicare beneficiaries receive care, from whom they receive care, or what type of clinical areas they receive care, and where those dollars go. So obviously, 20% or so in cardiology, 10% in diabetes and other chronic conditions, 7 or 8 or 9% in orthopedics. So having relationships and partnerships with specialists in these categories is essential for success in direct contracting, and no other program has created this type of incentive for this deep of relationship and partnership between primary care and specialists, and this level of risk sharing between primary care and specialists. And that's really what we think is a kind of a big game changer about this program. Let me pause there, Denny, see if you have questions or if there are other questions.
We do. We have a question from Janice. What happens when patients need a specialist who's not part of this arrangement? Can they go outside of the network, for lack of a better phrase? What does this mean for patients who might have more complex needs? Are they part of the risk pool, or are they constrained in their ability to see specialists? How does that work?
Yeah, so they are part of the risk pool and they're not constrained. So this is still a Medicare fee-for-service program. It's not a Medicare Advantage or managed care program. So there's no restriction on the choices that the beneficiaries have in terms of where they go. There are some, I've got a slide coming up on this. There are some patient engagement, so ways to sort of engage with patients in different ways and create some level of incentives, but there's no restrictions on where patients can go.
And this is on the professional side only. Is that correct? This is looking at the money that goes into the physician side of the equation as opposed to the facility side. Is that correct? Or am I missing that?
No, it's 100%. It's 100% of the budget.
It's all in.
Yep.
Okay.
Yep.
There we go. Thank you.
Yep. And one thing we learned by participating in the bundle payment program, right? So if you look at a patient who has a bypass surgery, for example, obviously they're going to have a surgeon. That surgeon is going to work at a hospital or a handful of hospitals. And then they're going to need some sort of cardiac rehab post-surgery, and possibly a skilled nursing facility, and possibly home care. That would be a 90-day episode in the way that Medicare creates it. And once in our experience, once the surgeon started taking risk, the surgeon in their organization started taking risk for the full episode of care for 90 days, all inclusive, any readmission is included, the cost of post-acute care is included. Once they started taking that risk, they started paying much closer attention to the quality and value that was delivered by the downstream providers, and includes everything, right? So how good is the nursing team at the hospital that I work with, in the discharge planning team, to get those patients prepared to go on to their next site of care? And then once they leave, how good is the SNF that they go to and the home care agency that they go to? And so as we evolved, we have a lot of data. We develop these preferred provider networks, downstream from the surgeon in this case, and really trying to make sure that those patients are folks are paying attention to those patients, and they're getting care from good providers at every step of the way. This program essentially just backs that up one level and says, okay, if I'm a primary care physician and I'm referring to a knee replacement doctor, I want to make sure that whoever I refer to, not just only do they work at the hospital I like, or they're not going to get punished because of the leakage report, but actually the surgeon who my patient is going to is really good at what they do. And the hospital where they work has low infection rates, and they've got a good discharge planning process. And that if they need to go to rehab, they're going to a good physical therapist. And, I know there's a lot of great providers in Boston and across the country. In our experience in fee-for-service, most providers are not intimately aware of the quality and outcomes of the people that they refer to. And again, it's not true for everybody, but in fee-for-service, it's generally true. And these programs change that 180 degrees, because now you're accountable for who did the bypass surgery on your patient.
So if I'm a primary care physician and I'm employed by my hospital, and I want to see, obviously I don't have contractual relationships directly, but I would think even if I were a primary care physician who was independent of the hospital or hospitals that I admitted my patients to, that I would want those organizations who have the capital and the resources to do some of that legwork for me, as a way of me feeling like this is a value to me. I guess it gets to the question of, if I'm a primary care practice, or I'm a primary care physician, I need a lot of data. I need to understand where I am going to get hosed or where there's opportunity, and I need to be able to do that while I'm seeing the 3,000 patients who are on my panel over the course of a given period of time. This is a complicated shift in sort of the center of gravity around the patient's relationship with their primary care provider and the primary care provider's relationship with the community at large. What kind of data do providers need to make this kind of shift? What kind of information do they have to have at their disposal so that they can begin a process that's completely different from anything they've done before?
Yeah, so I have some slides on that down the road, but it's hard, and it historically has not been available, and there may be some primary care physicians on the line who may agree or disagree with this, but I've talked to a lot of primary care doctors. I've talked to a lot of specialists. Most primary care physicians that I've spoken to do not know the specific, the data-driven details on the specialists that they refer to. And it's very hard to come by. It's getting easier, but it's very hard to come by. And in most individuals, whether it's primary care or not, most individuals make their choices based on, word of mouth and things like where a specialist might have gone to school or claims against them or those types of things. It's typically not based on, broad sample sizes of, how expert is this doctor at this particular thing, or how good are they at this particular thing. And I'm not arguing those are easy things to get your arms around, because it's certainly complicated. But I would say that, if I have a family member who's going to get some sort of specialty service, I'm going to look at a lot of data to try to figure out if this specialist is the right one for them.
Thank you.
So there are quality measures in the program. Medicare has really made a push to try to make this move away from kind of very broad HEDIS type data sets and make this process a little bit more streamlined. They're still developing some of the quality metrics related to this program, but it's centered around things like readmissions, unplanned admissions, having advanced care plans in place, CAP surveys, and those types of things. They're talking about working in patient-reported outcomes and different aspects of the quality measures. There's also metrics around reporting on different activities, and those types of things. And then, as I mentioned, there's a variety of waivers, both on the care delivery side, which is on the left, things like 3-day SNF waivers and expansion and access to telehealth, waivers to the Medicare home care homebound requirement, some cost sharing opportunities. And that's really around limiting or eliminating deductibles in certain circumstances. And then on the patient engagement incentives, you can provide vouchers for certain types of services to try to encourage patients to either see different specialists or use different types of medications, travel vouchers, incentives to participate in wellness programs or to use technology tools, and those types of things. But again, it's a fee-for-service program, so it's relatively loose incentives as opposed to like a Medicare Advantage product, which would be narrow network type of structures. I think a number of keys to success. I think this, as folks can tell, I'm pretty animated about this program. I think that this will really change the way primary care is delivered to Medicare beneficiaries for folks who participate. Certainly, transitioning away from fee-for-service to capitation, which is a big transition. I would expect to see for healthy Medicare beneficiaries, relatively healthy Medicare beneficiaries, you will see physician panel size expand and a broader use of other types of caregivers like nurse practitioners and advanced practitioners and PAs and that type of thing. Certainly more engagement with telehealth and other types of technology. Real segmentation, more careful segmentation of patient populations. And so I think panel sizes would shrink for patients with chronic conditions who need more attention and more focus. And so, things like diabetes programs would expand, or sophisticated programs to manage patients with CHF or multiple chronic conditions would expand. This issue of really working hard to develop preferred relationships with high quality, high value specialists will be huge. And then also, making sure that you can finance that you can protect your downside if you participate in these programs. On the specialty care side, proactively engaging with groups who are participating in this program and entering into these preferred referral relationships, ability to use data to demonstrate that you're really good at what you do. That is going to be increasingly more important. And as primary care, these organizations choose to whom they will refer. It's going to be much more data driven than it's been in the past. I think for specialists, the ability to enter into risk arrangements could start with a pay for performance deal, like we talked about earlier, transition over time to a bundle payment, ultimately possibly to a carve out for, we talked to a large orthopedic organization recently. They want to carve out 100%. Well, all the codes that would be related to orthopedics, their responsibility for a defined population, and to get paid a PM for doing that. I think if that were the case, you'd see less unnecessary spine surgeries, right? Or other types of surgeries. Easy access for patients who are affiliated with a direct contracting organization, because they'll be measured on their ability to get patients in the door, sharing data between primary care and specialty care, and managing the process, for care process of care for patients who are in some type of chronic or acute episode in a proactive and collaborative manner.
We've got a couple of questions that just came across the transom. With a dearth of MD grads going into primary care, can this system work given the reliance on primary care coordination?
Yeah, I'm a contrarian. We have way too many doctors. Fee-for-service is a skewed economic system where supply drives demand. And we just, almost no one in our system is operating at the top of their license.
How are PCPs being educated in this model? How do they get to know what they can do and where they fit and how to manage this brave new world?
Yeah, it's a
You're
good
doing
question.
it. I guess you're doing it, right? That's the answer to that question, right?
Um, we're trying. Yeah, I mean, I think it's a very good question. So if you think about the direct contracting program, it was announced in late 2019. It was announced in mid 2019. The request for applications came out in November of 19, and the application was due in June of 20. Well, in June of 20, everyone was pretty distracted. And so what they did was, it was supposed to start in January of 21. So they did two things. They delayed the start to April, and then they added another application period. And so the next round of applications is due this spring. They haven't said the date, but we expect it to be June. And for the January 2022 start. It's definitely below the radar screen. I mean, the folks who have applied so far are really combination of kind of the Agilon and Ioras of the world, and new entrants. There's kind of startups that have been applying and things like that. Not a lot of providers yet. We think there'll be a lot of applications in the next round in June, but it's definitely below the radar. And you can never tell with CMMI. They never exactly say. They don't like to say we're going to have multiple enrollment periods, because then people will wait. And so they basically say this one could be the last one. I suspect there'll be more enrollment periods over time. But as of today, the next and only opportunity to apply is this spring. We're seeing more and more interest in the market, but it's certainly below the radar screen. It's a 5-year program. And we'll see if they have more application opportunities beyond this next one.
Are these programs driving physicians to or away from the organizations that are adopting them? If I'm a primary care physician, do I want to be a member of a group that's actively participating in this program, or would my inclination be to steer clear?
So I think there's a lot of benefits for participants. And particularly for primary care organizations. It's not for the faint of heart, for sure. But I typically, if you're a primary care organization, and this is data that published by Medicare, if you're a primary care organization, typically 3 to 4% of a Medicare beneficiary's annual spending on healthcare is spent on primary care, or collected by a primary care provider. In this program, they'll essentially advance primary care providers 7% of the budget. So, close to doubling, or about doubling of the revenue for primary care, just in that portion. And then, it puts primary care organizations in a much stronger position to control the referrals and the dollars for downstream spending. And improves cash flow, as we talked about, so you get consistent monthly cap payments. The upfront dollars that come into primary care, we would argue, create a lot of opportunity to improve process, rethink. One of my favorite conversations to have with physicians, Denny, who have any specialty, is if you forgot about how you get paid, how would you organize care for patients in your population? And first, it's hard. I often find it hard for the provider, the physician in this case, to sort of even think about that, because we're so tied to fee for service. But once you kind of get in the conversation, no one would design it the way that it's designed today. Not a single specialty, primary care included, would design the way they deliver care the way that it's designed today. And so if you can say, we're going to give you a bunch of money and some risk for sure, we're going to give you a bunch of money and we're going to pay you in a different way, set it up the way you want to set it up that's best for you and your patients. It's a huge opportunity. Just from a satisfaction of job perspective, it's a huge opportunity, but it's also it's a real change, change in the way it's a shift in the way the dollars flow. And I think to the advantage of primary care and to the advantage of specialty care, if they can kind of think about it in the right way. We think it creates more control, more control of the dollars and the process. Could create the opportunity for greater independence for the right types of organizations, and definitely, back to the beginning of the conversation, definitely, if Medicare moves in this direction, providers will be much more well prepared to kind of, do this with other payers.
We have a comment from Yael Miller, who is with the Massachusetts Medical Society, that initial reactions from a few primary care physicians that MMS has talked to about this is concerns about the lack of infrastructure support and concerns about returns. Is there kind of a minimum necessary scale where a practice, a group, a group within a hospital setting, what are some of the sort of the barriers to what constitutes the minimum scale that would enable a primary care physician to say, I can make this jump?
Yeah, so I think there's some, I appreciate the question. That's a good, and I think there is a lot of, there's a lot of moving parts and complexities. This is the RFA here. It's in Medicare has published another half a dozen documents that look like this related to various aspects of the program. So it's complicated. I would say the 5,000. So there's a 5,000 beneficiary minimum to become a direct contracting entity. And that's designed on purpose. Actuarially, it's hard to make this work below 5,000 members. And so I would say that's a threshold. I think for primary care organizations, though, there's a variety of ways to participate, right? So you could be, if you're part of a health system, your health system could be the direct contracting entity. If you're independent and you're large enough, you could be your own direct contracting entity and execute the contract with CMS and own the risk yourself. And we're underwriting providers who are doing that. So there's protection on the downside. We're going to become a direct contracting entity. So for smaller groups who want to, participate, but aren't large enough or don't want to take the risk themselves. And we're not the only ones. There are others that are doing this as well, but there's, ways to kind of pool providers together to get into these programs and manage the risk and get to enough scale and manage the risk in different ways. But I get it. It's complicated and there's and it's big change and it's a lot of moving parts. And this could be perceived to be kind of a crass MBA statement, but there's a reason Oak Street's trading at valued at $13 billion. And they're in the Medicare Advantage. They're doing basically this same thing in the Medicare Advantage space, and they've done very, very well. And Medicare wants to figure out how to move more of their population into some type of managed structure. And this is the way. Now, there are differences in this program, certainly on restricted networks and those types of things. So not suggesting it's going to be easy or even sure thing, but I do think we're going to see providers who will be quite successful at this.
Suzanne Young also asks, could you elaborate on the care management that is required up front and the investment associated with that? What would that entail, or what is the goal for primary care's undertaking that kind of care management investment?
Yeah, so I would say we've got a lot of experience working with providers who have gotten into these programs, and some in experience with many who've been successful, and a good number who haven't been successful. I would think that the things that distinguish the ones that have been successful from the ones that haven't, first and foremost, is leadership. is clinical and administrative leadership of wanting to do this and wanting to get into it at the most senior levels of your organization, and commitment to moving in this direction. We work with a oncology practice, independent oncology practice in Northwest in Seattle, in the Seattle area. They've been really successful in the oncology care model program, seeing improvements in their demonstrated improvements in the care they're delivering, and they've earned savings in that program. And the biggest thing that's made them successful is their founding oncologist, Sibel Blau. She is 100% committed to this, and she recruits doctors based on their commitment to this. They've fired doctors who don't buy into this, and they're moving toward this, models like this. And their CEO is arm in arm with her. He's a PharmD, and so he really understands the drug side of things. And so, from a leadership perspective, they couldn't be more committed to it as an organization, to moving in this direction. Then sort of from there, understanding your patient population, using, both from what you do every day, but also using data to really understand who your patients are, what their needs are, where they're utilizing resources, are they utilizing resources in the right way? So if you have, we work with a panel of primary care physicians. I didn't know this. I learned this recently, but they told me that a third of their panel is diabetic, and it's typical for primary care physicians to have about a third of their panel be diabetic. I don't have the data, but that's what I've been told. And that makes sense. I mean, diabetes is a huge, very high incidence of diabetes. I can guarantee you every primary care physician isn't great at managing diabetes, but they have to have diabetics on their panel to make their business work in fee for service. And so, but if you have a large practice and you have a lot of diabetics, you have to have a diabetes management program. And you should be thinking about, continuous glucose monitoring and counseling and those types of things. And so just knowing your patients, what their needs are, where they're getting care for those needs, and is it the best care that they can get, or that you can help them get. So one of the benefits that we have is we have all the data, right? So we know where every provider is referring their patients to, and we know what volume, how much volume is being sent there, and then we've assessed every specialist in the country, and so we know whether those specialists are great. And so being able to know where your patients are going and know that when they go there, they get great care is another key part of it. Using technology, telemedicine, and the ability to engage with patients in different ways, and fee for service, you have to bring them in to sustain your business. This will change that. So those are a handful of things.
It strikes me, one of the things that we see in the marketplace is, primary care practices are struggling in many cases, and one of the only options available to them, at least before this, was employment at a hospital. Join a hospital, have your practice be acquired. This strikes me as, a new path for primary care and for specialty care that, with the right support, enables practices to continue, more practices, if they're innovative, to continue as independent actors rather than as employees of the larger health entities. Is that a fair assessment, or is that something that you see differently?
I think it is a fair assessment. I mean, I think that, but I think it could be interpreted either way, to be honest. I mean, I think that, and I think either one of these reactions are reasonable. One reaction could be, this is just completely overwhelming and things are changing, so quickly and so dramatically. I need a big partner. And that big partner could be, the health system, or that big partner could be Optum, or private, another type of private equity investment, or something like that. So certainly could see that happening. I also expect to see, we're talking to some of them, um, folks who are still independent tend to be pretty fiercely independent. No one out there who is independent hasn't had a dozen opportunities to not be independent at this point. And so, if you're in that category where you're fiercely independent and you want to figure this out, this is a great model to kind of change the game for, change the, I want to be so euphemistic, change your revenue model and change your kind of position of influence in the market.
One more question. Do you see more of the care moving to primary care instead of specialists under these programs, given that primary care is building relationships with specialty providers for everything from diabetes to chronic, congestive heart failure, for example? Do you see primary care managing diabetes, or them saying, we're going to send this to an endocrinologist who's really good at this, or a diabetes management program with whom we have an arrangement? How much does the primary care have to do themselves? Does the patient go to the primary care doc and that's it, like the old gatekeeper model? Or is this one where there are different types of arrangements possible?
Yeah. So I think of primary care as a specialty, right? So we're all specialists, and at this point in our career, we're all specialists in something, right? And if you're a primary care physician, there are things that you need to be really good at to be a really good primary care physician. And so I would say if you're a quote unquote primary care organization, and you have, in your sizable organization, maybe you have 2,500 diabetics in your panel, in your collective panel across your physicians. That would actually be a relatively small number. It would be a relatively small group if a third is diabetes. So you have 7,000 diabetics in your community of patients. I think it's perfectly reasonable to say that we're gonna keep them in our primary care practice, and we're gonna care for them in our primary care practice. But you got to be really, really good at caring for diabetics. So you got to have a diabetic program that is managed within your practice, maybe help developed with consultants from endocrinologists and access to endocrinologists for complex diabetics who need that service. So I'm not opposed at all to saying, look, we're going to manage these 7,000 diabetics, but it's got to be done in a way that is specialized and really good. Otherwise, those diabetics aren't going to get the best care. And secondly, they will start to blow through your budget.
Thank you.
Okay, so a bit about data. So the way we think about, so we're underwriting, right? So, and this, I guess, Denny, gets a bit to your question in terms of sort of independence versus having to join a big system. Part of the reason why we moved towards underwriting is we wanted to facilitate more involvement in participation in these programs, and risk, the risk financing is a barrier to folks to participate. And so, and we partnered with an insurance company who's got pretty efficient capital to do this. And so we want to kind of try to separate, who's really good at providing care from who also is willing to take the risk, because those two things aren't always concentric, right? And so, we want to partner with folks who are passionate about, delivering great care, and then help them finance how to do that as the market moves toward risk. And we think about the risk in three different ways. There's programmatic risk, right? So we just went through all these, rules of the direct contracting program. We only touched on a handful of kind of the big picture rules. There's tons and tons of rules with how the program works, how the benchmarks are set, and how reconciliations are done, and all that. We have a team, we call the policy and solutions management team, it's their job to really understand how all these programs work. And so they read the Federal Register, they talk to providers, they talk to CMMI, and they document. We spent a lot of time in the chronic kidney care program, a lot of time in the radiation oncology program. We spent a lot of time in the direct contracting program. And so we really understand how the rules, incentives work. And then we model those programs through our data sets to try to understand how they behave. The second type of risk we think about is provider performance risk. So, if a provider is thinking, if a primary care group, for example, is thinking about getting into the direct contracting program, we're going to want to look at what their historical performance looks like for their beneficiaries that are assigned to them, and how does that performance compare to the rules of the program and the budget that they'll receive, and what does that mean from a risk perspective and an opportunity for gain and for improvement. And then also we're going to want to look at, where are their patients going downstream for diabetic care or orthopedic care or cardiac care, and what is the performance of those providers that they're sending their patients to, and what does that mean for their opportunities and risk as they get into a program. And then the third would be, general insurance risk, which is things like how big is your pool of patients? What is the actuarial, modeling of that say? What does risk simulations look like in terms of probability or gain? And how can you improve those probabilities by changing care patterns or investing in care management or changing your referral patterns and those types of things. And so we use a lot of data to do this. This is just an example of looking at knee replacement. We did a study recently for we have an employer that we work with who had an employee who had a patient who had a meniscus tear and was pursuing meniscus surgery. And what we found, there are about 350 surgeons in Eastern Massachusetts who do that surgery. There are 12 who do 150 or more a year. And so, but there are a lot of them that do surgeries on the right side of this curve, relatively low volume. It's a relatively small part of their practice, but they do them. And there's a handful who really are experts at this, who do this, day in and day out. And so we really want to kind of know, who those folks are. And then we want to look at things like complication rates and ER, post-surgery ER visits and readmissions and those types of things. And we see variability everywhere, right? We see it in orthopedics and cardiology, and we're really trying to look at an episodic or procedural perspective, on these things, and who is it that you would really want to see. This is a real study. This was an employer we've done some work with over a 2-year period. They had 18 different patients get knee surgery. They saw 16 different doctors. Some of those doctors some of them were in our top 25th percentile for their performance for this particular procedure. Some of them were not. And the range of cost was, $30,000 on an episodic basis. So that's, for the surgery plus 90 days, range from $30,000 to $95,000. And so there's just a lot here, right? So there's one employer, they saw for 18 procedures, they saw 15 different doctors, 18 surgeries in the same clinical area. They saw 15 different doctors. A lot of those doctors were low volume, and some of them were not high quality according to our benchmarks, and 200% range in total price. And so I don't think people are going to buy healthcare this way anymore. I don't know if it's going to happen tomorrow, but I just think that, consumers are going to want to choose more wisely. Primary care physicians, if they're taking risk, are going to want to choose more wisely. Employers who are paying for a significant portion of it are going to want to help their employees choose more wisely. And I can't predict exactly how it's going to play out, but this data is more and more available, and I think guiding choices more and more actively. This is not just in orthopedics, right? So we see variability everywhere. This is looking at the episodic cost of care for patients with different conditions. Each line is a physician. And so this is, attributing patients to individual physicians. Each line in each graph is a physician. And, there's some risk adjusting in here. It's not perfect, but certainly we have the ability to do more and more risk adjusting and look more closely. But we see variability everywhere you look, right? We see variability in prices, in quality. Healthcare is a multi-trillion-dollar industry that is unique in that price is not correlated to quality. I don't think that's going to last forever, but we certainly see that, and we think choices. The way people choose is going to become more cohesive than it has been in the past. So I know we've done questions throughout. I know we've only got less than 10 minutes left here. Happy to, 2 hours is a long webinar, Denny. I hope it hasn't, I feel like I've been talking a lot, but I hope it's been helpful.
Well, Dave, we have almost exactly the same number of participants now as we had at the beginning of the webinar, which is a very good sign. Okay, so I think you needn't be concerned about that. I think this is extremely informative. We're seeing some things happen now that are changing the economics of healthcare too. Given COVID, we've suddenly seen the explosion of telemedicine. New technologies, remote patient monitoring, home-based monitoring, care delivered in the home rather than care delivered in, a high-cost facility. These have market-moving potential. Could you talk a little bit about how these transformations, these technological sort of disruptions and innovations are going to change value-based care?
Yeah. And I think it's, one simple answer is it's in the difference between, fee for service payment and a prospective capitated payment, right? So this will not be a fair call out here, but my for a long time, my primary care physician was at Atrius. Atrius is capitated for most. My understanding is Atrius is capitated for, much of what they do. They have more risk contracts than most providers in the country. This is a few years ago, but I had a simple skin issue, and I called up Atrius and I said, "Geez, can I just send my doctor a picture or do a FaceTime?" This was pre-COVID, and I just talked to an administrative person on the phone, but they were like, "No, we don't do that. You have to come in." And I didn't want to go in. I didn't need to go in. It was not a big issue. I would have happily paid $50 or whatever to not go in, or more, I think, or would love to have my plan pay for it. But they just weren't set up to get paid that way. And I think and now that's obviously changed a lot with COVID. I've done, probably everyone on the line here has done a telehealth visit in the last year. But I think, programs like this what I love about programs like this is it puts the physician in charge of deciding where the patient should get care next. And it's not driven by what the code says that Medicare or Blue Cross will pay for, right? So if the physician feels like that, they can deliver care in a telehealth visit for this particular need, they can do that and be remunerated for that. If the patient has to come in, if they feel the patient has to come in, they can do that. Or if they feel like the patient needs a referral, they can do that. There's another company that I think, I don't know, I think I maybe saw you doing a webinar with them, but Medically Home. So I know Medically Home pretty well.
They're coming up. We're talking to them in about a month's time.
Yeah. So I know Raphael and his team. Well, they've been around for a while. I think they've got a great model. I've been to their brain center in Kenmore, where they're monitoring patients and things like that. I think they're doing great, but their biggest challenge is they can't get paid. because there's no code for delivering hospital care in the home. And then again, you'll learn about, my data is probably dated, but I know I've had this conversation with them. But if the doctor and the medical group think that they could benefit by having, monitored care at home and not go to a hospital where it's going to be a lot more expensive and infections are going to be a lot, exposed to more infections and things like that, you can make that choice and not worry about, is Blue Cross or Medicare going to pay me for that?
One last question before we wrap up. We have the burden reduction work that CMS is doing, focused, not exclusively, but primarily on prior authorization. And prior authorization is really an artifact of fee-for-service medicine. I mean, it's how do you avoid going over? How do you manage your exposure as an insurer to practice-based risk and to some of the perverse incentives in fee-for-service medicine? Do you see these physicians being able to, or these value-based arrangements, these models, fundamentally changing the whole idea of prior authorization? I mean, the physician becomes the prior authorizer in some respect. Do you see that being a major change in how physicians go about making their decisions and what kind of barriers or what kind of gates they might have to clear in order to do it?
Yeah, it's a good question. I wish I had a great answer on that one. I mean, I think it gets to this telehealth question too, though, right? Which is, telehealth is great unless everyone gets a $50 telehealth visit, whether they want it or not. Telehealth is sort of like Zoom meeting. All of us, I mean, I've had probably twice as many meetings in the last year as I would have if it wasn't for Zoom. The barrier to do a meeting is just so low that my calendar gets filled up with all these Zoom meetings. I don't have to get in my car, and I don't have to, and I can't walk down the hall and see someone. I do worry about the opposite, right? Which is all of a sudden everybody gets a telehealth visit, whether they need it or not, and that generates fees or costs of some type, or everyone gets a medically home 10 days with medically home in their house, whether they needed a hospitalization or not. And that starts to drive up costs. And another, you have the squeezing of the balloon problem. So I don't know that prior auth is going to go away. But hopefully it'll be, I think technology can help it be much more streamlined. But I still think there's going to be some mix of clinical discretion and some prior auth process.
Great. Well, I can see that people are starting to sign off. We're just before the top of the hour. Dave, Terry, as always, this has been a fascinating, informative, terrific presentation. And I want to thank you on behalf of the consortium and for our attendees. Folks, we will be having this presentation as well as a recording of this webinar available on our website. I believe Lynn put up the link to the website earlier on our chat box. And David, thank you again. And with that, I will adjourn our meeting.
Thanks, Denny. Fun as always. Thanks, Arlene. Appreciate it.
You're welcome. Thank you.
Bye-bye.
Bye-bye, everybody.